Good evening, everyone, and thank you for joining us for this important session on rescue and preventative management of migraine. Before we begin, I'd like to take a moment to introduce PENJ Primary Care Network, the PENJ PCN. PCN is a collaboration of six GP practices working together. My name is Shabana, and I'm the Digital and Transformation Lead. I'm pleased to be facilitating this evening's session. We are delighted to welcome our guest speaker, Andrew Dawson, an expert and associate specialist. We'll start with the presentation, followed by a question and answer session. With that, I'll hand over to Dr. Dawson.
Okay, thank you very much. My name's Andy Dowson. So I am now towards the end of my career, so in my 60s, but I've been working full time in headache from about the middle 30s. So I've got quite a lot of experience. I was the chap who set up the headache service at King's. I now still work for King's, but also run the Bromley GP Alliance Headache Clinic, and one of Shabana's colleagues worked with me in that service. That was a lady called Sophie Michael. Okay, so that's how I end up speaking to you. I've been asked to talk to you about migraine and its management. And before we kind of get into the treatments, probably the first thing to say is that before we get to a treatment, we have to get a diagnosis. And the two kind of broad areas that most people get referred to people like me for is an uncertain diagnosis, there's diagnostic uncertainty, or there's a treatment failure. Those are the two major areas. So although we won't have time to talk about every type of headache, it's probably worthwhile just trying to kind of separate the different types of headache. So the first thing to say is that virtually everybody gets a headache at some time in their life. It's 97% of the population, and 70% get a headache at least every month. And everybody's worried that they're going to have that the headache is going to be the first symptom of something that's really kind of scary, a burst blood vessel or a brain tumor or something like this. And that's actually not usually the likely cause at all. So most people's headaches are what we call benign, and they are usually a primary headache. So it's not secondary to another problem. It's actually that you have that type of headache as your main illness without it being caused by something else. So the numbers are that less than 1% of all the people who have a severe start with a headache will have a severe or secondary cause. So these are usually kind of blue light scenarios. So people collapse and have their first or worst headache, they're taken to casualty, or if they get inflamed arteries, it's a thing that happens over hours and days. So these are acute presentations, and it's less than a 1 in 100 people will ever get those at any time in their life. So the most common types of headache are what we call benign. So the biggest and most common group in the general population are featureless low-grade headaches. They're called tension type headaches, probably affecting about almost 3/4 of the population every month. So these are the featureless ones. And then the ones that have features, just to say that they're normally better treated by drugs like the ibuprofen type drugs rather than paracetamol. Of the ones which are more impactful and have features, the easiest way to separate is that there is a group of people that would get them infrequently, so they would have them once or twice a month. So technically, if they have some sort of headache more than half the days of the month, we call that acute headache, whereas if it's on more than half the days, it's called chronic headache. And if you have acute headache and it's high impact, it's likely to be migraine. So about 10% of the people who have migraine every time they have an attack have the flashy light zigzag lines, the auras. 40% sometimes have those symptoms. When you have those, they're called classical migraine symptoms. So the more common types, the types that don't have those, are called common migraine. And that's what we see in general practice mostly, is people who have every now and again severe headaches which cause disability. So they're the people who mostly consult the GPs. The people with chronic headache, the ones where the headaches are more days than not, fall into two groups. The type where the headache is there much of the time, and the type when the headaches are actually quite short, lasting seconds or minutes up to a few hours. So the shorter ones are called the trigeminal autonomic cephalalgias, and the main condition in that group is called cluster headache. And it's about one or two for a GP to manage in their career, so they're not very common. But they have their own special treatments, and these are very intense headaches. For the cluster headache, it lasts between 30 minutes and 3 hours, and the eye goes red and watery, and you pace around and want to hit your head on the wall. And the shorter versions of that type of headache, lasting for a few seconds, is called idiopathic stabbing headache. And there's one a bit longer, which is called short unilateral neuralgiform headache, 5 seconds to 5 minutes, and then one 5 minutes to half an hour, paroxysmal hemicrania. They are often things we see in the clinic, but they're not the same as migraine. There are different diagnoses with different treatments. And then the headache where you have headache pretty much all of the time is called chronic daily headache, and it either has migraine features or not, generally, and it can be complicated by taking too many painkillers. So if you take painkillers more than 2 days in the week, particularly with codeine and caffeine, it can make that situation worse. So all of that seems very complicated, but broadly, we ask a few questions to tell us which group you fit into. So, when did you have your first headaches? If it were a while ago and it's not a fresh sort of presentation, it's unlikely it's going to be any of those sinister causes. Does it cause impact or not? If it's not impactful, it's probably going to be episodic tension type headache responding to simple painkillers. If it's going to be high impact, is it there a lot of the time or just every now and again? Every now and again is likely to be migraine with or without the aura. If it's a lot of the time, are they short, lasting a few hours, or most of the time? And if it's most of the time, have you got the complication of the overuse of painkillers? And that's the structure that really puts people into the right diagnostic groups. And probably when people are listening to this, they will be thinking, oh, well, maybe I fit into the area that I thought I did, or maybe there's a question mark and I need to just have that diagnosis reconfirmed. And that obviously that's something that your GP could help with, or you may need a referral to a specialist clinic to help to kind of untangle the symptoms. Okay, so that's the beginning kind of introduction. What I was asked to talk about mostly was migraine and the treatment of it, and we've got two kind of panels of slides which we'll just kind of quickly talk through. They were designed for patient groups by what is now an organization that doesn't exist anymore called Migraine Action, but it was the patient group for migraine, and I've just adapted them slightly so that we've got the more recent kind of innovations also in the slide packs. So let's just put the slide up, Shabana. The first slide. Yep, there you go. So the first slides there, and she's put the preventative ones up first. Can we do the rescue ones first? That's it, acute treatments. So the first thing to say is that people will call these types of treatments different things. As well as acute treatment, you might call it your relief medication or your rescue medication. So these are the things that you take when you have a bad moment to try to nip the attacks in the bud and don't let them to build up. So the best time to try to get a handle on an individual attack is early. If you delay the treatment, it often makes the treatment less likely to be effective. So we have got a number of different options available to us, and there's a few different ways of trying to deliver the strategies. So do you want to just do the next slide? So these are some of the things that might be considered when you're thinking about what's important to you. So in medicine, we tend to kind of do a lot of our thinking based upon what happened in clinical trials. And the clinical trials are usually built around over a certain time period. If you can relieve your symptoms, can you get rid of the headache? If you get nausea, light and sound sensitivity with migraine, can you get rid of those type of symptoms? And so we're looking, we would need to show that our new medication was better than the pretend medications at half an hour in these different fields. So that's what efficacy is about. And the most common one is that we say to people that your mild to moderate migraine should become mild or absent within 2 hours. And that's because 2 hours is probably a reasonable expectation for you to start to see some benefit from a rescue drug. But, that's what we do as doctors. In fact, many of the patients say, well, that's too slow. I want it much quicker than that. Or I'm more interested in having some sort of response that allows me to continue, but it works every time. And it's no good if it only works once in 3 goes. I want something that's a lot more effective. Or perhaps, you're worried that you might get a side effect from a drug. In fact, the reality is that for rescue drugs, people will often put up with side effects to get more power, more control. And sometimes you're very interested in not just something that would get rid of it, but then the headache wouldn't come back and you need to take another dose maybe later in that day or the next day. And for some people, it might be the ease of use. So, but taking a nasal spray or an injection would be very difficult for someone. It's much easier to take a tablet. Or some people won't like tablets because they've got a dry mouth, they can't swallow, so they need to have a glass of water. So they prefer a different type of medication. So although medicine tends to always think about getting rid of the headache in a certain time, that may not be your priority. And sometimes that's a discussion that needs to be had with whoever's advising you to see if they can give you something that would be more appropriate. The next slide. Got the next slide, Shabana? Oh, okay. So go back one slide. I think you jumped a slide there. So that's where I was saying that the realistic aim from a medical perspective is back to your normal activities in 2 hours. So you can see that we're already beginning to think, rather than just broadly, could you get rid of the headache? We're actually looking at, rather than getting rid of a headache, can we actually get you back to your normal activities? So that might be a mixture of something that works but doesn't have a side effect, because if it didn't work or it had a side effect, you couldn't get back to doing the things you needed to do, for instance. So some of the endpoints start to become more and more complicated when you were trying to assess them for patients. So the next slide. So when we're tailoring the treatment, we might be looking at a whole range of different factors. So an interesting one on this slide was just to say that the impact on daily living can be the most important thing for some people. So, now you've actually got something that works, whereas before you were missing time from work or you were unreliable picking up the children from school. Are you beginning to become more reliable? And in the collective, we tend to think about attacks, but in fact, it's all the time in between attacks are important as well. So basically, if you look at a period of time, a month or 3 months, is overall the impact on your daily living improved or not improved? And there are questionnaires that can help to look at that. So you can look at just the attack, or you can look at the overall kind of holistic thing of how somebody lives in their life, and how factors such as work absence or mental health are also playing into this. And obviously we have to think about other illnesses as well. Right, so the next slide, yes, Shabana, you're getting the flow of this. So these are the over-the-counter drugs, the kind of things that you can buy yourself that you might take as a rescue. And the aspirin Nurofen family, which are the non-steroidal anti-inflammatories, are usually better than paracetamol for both the tension headaches and the migraine headaches. Caffeine can allow those drugs to absorb quicker and get into the brain quicker. But if you take caffeine in your drug, you're 4 times more likely, to develop something called chronic headache, where you end up getting a higher frequency. So although it helps on the day, it pushes down your threshold, but makes it easier to have the next headache. So the danger is that you get a better response, but you end up taking more and more and more medicines to keep up with the control of the generation of a new headache. Antihistamines, some people used to use those. We don't tend to use them so much now for acute treatment. And codeine has the biggest effect on that lowering of the threshold. And the term medication overuse headache can be relevant for all rescue drugs more than twice a week. But when codeine's involved, caffeine as well, if those drugs are involved and you stop the drugs, they continue to give you more headaches for up to 3 months, having stopped the drugs. So you have a long tail to the effect of the increased frequency. Next slide. So we were talking about the timing of treatment, and it's best to take the painkillers right at the beginning if you can, and make sure you're taking a proper dose. One of the issues in migraine is the stomach doesn't empty, so the absorption of the drugs can be sluggish. So quite often the initial dose might be a bit of a bigger number than it would be for other conditions. So generally speaking, with a paracetamol or aspirin, rather than 2 tablets, 3 tablets might be suggested, not for each dose, but just at the beginning to kind of get the ball rolling and get enough absorbed to have some effect. So we just need to be aware that sometimes there are a whole number of ways of being given drugs, and you might be taking paracetamol, for instance, and then you might have another painkiller that also has paracetamol within it, and it isn't necessarily clear. So we just need to be sure that we're not taking too much of any of the individual elements, particularly if you're using more than one medication, and obviously follow the manufacturer's instructions if possible. So next slide. So anti-sickness medicines. Part of the problem of migraine is that your stomach doesn't empty very well in a migraine. It's called gastric stasis. And as the drugs are absorbed beyond the stomach, this then slows down absorption. And the 2 drugs mentioned, domperidone and metoclopramide, are prokinetics. So these are anti-sickness medicines that can help with the nausea, but can also help with the other drugs absorbing better by overcoming the gastric stasis. We don't use so much of the domperidone now because it can cause an abnormality in the heart rhythm. So it can stretch something called a QT interval, which makes it more likely to get palpitation. So although that was available over the counter, it isn't anymore. And we most commonly used Maxolon, or metoclopramide is the other name for it, the proper name, on a prescription. So a painkiller like ibuprofen plus metoclopramide, because the metoclopramide allows it to absorb better, you end up with better outcomes. Next slide. There are a lot of other anti-sickness medicines, and they generally work mostly on the chemical trigger zone in your brain. So they allow you to have less nausea, but they don't help with the gastric stasis. So a drug like Bucostem, so this is one of the drugs called prochlorperazine Stemetil. You can buy it and you can chew it, and it absorbs from your gum. So if you're actually being sick, it can help to stop that vomiting, but it doesn't help with the gastric stasis and absorption of other drugs. So if you're already vomiting, obviously you're not going to keep anything else down that you take. So this might be useful at minimizing that individual symptom. And there's a whole range of drugs that work similarly on that chemical trigger zone. And there's others that work actually in the brainstem, which were developed originally for people on chemotherapy. And they work in a different way as well, and can also be used for people with intractable vomiting. But the most commonly used are the ones with the gastric motility agent action. Sorry, new slide. Okay, so then we sort of move on from those basic building blocks to the more prescription version. So a more powerful anti-inflammatory than aspirin or naproxen. So the middle strength ones are drugs like diclofenac and naproxen, and the strongest of the family of the non-steroidals is indomethacin. And as you drive for more power, it's possible you're going to get a bigger chance for indigestion and other side effects. So the one that generally on prescription we use most is naproxen, because it has the lowest chance of that QT elongation that I was mentioning for domperidone. You can get that with the non-steroidals, and it has least of that. And it is a middle strength drug, and usually very low, the lower end of the side effect profiles. So in fact, in the States, they have naproxen mixed in with some of the other prescription drugs, the triptans, in the same tablet because of its good action as a combination medication. So the anti-sickness medicines are sometimes mixed with the painkillers. So Paramax is paracetamol and Maxolon or metoclopramide. Migramax is an aspirin plus metoclopramide combination. So again, when I was mentioning, sometimes the names of these hide that there's some other medication that you might be using as well, and you've got to make sure that you're not overusing them. So then we come to the prescriptions, which are for migraine specific drugs. And the beginning of this actually was a gotamine. which is it was derived from fungus that was growing on certain grains, and people would go in Italy to certain places where they had where they thought that the bread that they were eating was stopping them getting their terrible migraines, and it was actually a fungal infection on the grains. And the problem with this was that the fungus actually it hits a number of different switches in the actual in the body and in the brain. They're called receptors, and not all of the receptors are that important for stopping the migraine, but they can have other effects. And one of the effects is actually reducing the blood flow to certain parts of the body. And so the ergotamines are pretty much not used in the UK. Some parts of Europe still have them. But some clever people in the 1970s investigated them and worked out the switches. And from their research and actually dialing out some of those receptors that were unnecessary and giving side effects, they came the triptans. And that was the big breakthrough, really, for the people with migraine in the 1970s and 80s. And we have 7 drugs now in the family. Now, I've mentioned at the bottom there that there's another family of drugs. So rather than working on serotonin 5-HT, working on CGRP, a different protein, we have GPANTs. And in some places, I work in Kent as well. And in Kent, we have those available, but not yet in Southeast London because of the budgetary issues to do with the hospitals in the area. So they will be coming. And in general, when you fail two of the triptans for side effects or lack of efficacy, we can use the GPANTs as an alternative, and they work in about the same number of people, but not necessarily exactly the same group. So they might be something that will also be of interest to those of you who are finding it difficult to find a rescue package that is consistently effective. Now, the triptans, you can just kind of put all of these up. There's a lot of extra ones to put in here. There's 7 drugs in all. And they come as all sorts of different doses. So broadly, the 7 drugs, the gentlest is called frovatriptan. And then the next one up is called naratriptan. The next one up is almotriptan, then sumatriptan, zolmitriptan, elytriptan, and rizatriptan as tablets. So there's an escalation of power, and most people start off with a middle strength triptan. So sumatriptan 50 milligrams is the most commonly used. It was the first of the triptans, has the biggest number of people that have ever used it, and effectively there are different ways of doing it. The nasal spray for sumatriptan is mostly absorbed actually by swallowing it. It's only about 5% absorbed in the nose, so not a big advantage. But the advantages for sumatriptan are there's an adolescent spray. So most of these are licensed from 18 upwards, usually to 65, but there is a license from 12 to 18 for sumatriptan in the 10 milligram spray. And there's this kind of wide array of different ways of giving it. The problem is it has 5-HT1A activities, an extra switch, which makes people a bit more nauseous, at least some people to begin with. Then as the headache goes, it clears. And all the other 6 don't have that 5-HT1A activity. So usually exacerbate the nausea less. I actually quite like the nasal version of Zomig, which is more powerful than any of the tablets. So Zomig tablets are about the same strength as the sumatriptan, but the nasal is the most powerful, and 30% of it is absorbed in the nose. So that 30% make it more rapidly effective. So I find that a very useful drug for my patients and a sort of trump card for those who are struggling to get a response from the triptans. And then other drugs which have a low side effect profile. Naratriptan 2.5 was designed to be a gentle triptan. So that's often used when people are getting a response but side effects. And rizatriptan is the most powerful tablet. So often if you're searching for more power but not a nasal or injection, you go with that. So there's an array of different treatments. We now have a pathway for doctors to look at in Southeast London to try to choose the best options. But most start off with with in an adolescent the 10 milligram nasal spray, in adults the 50 milligrams of sumatriptan. And there are subtle differences between them that the doctors will sometimes need to understand to get you the right treatment. So the triptans can be used in combination with the non-steroidals and also the prokinetics, and the little cocktail is likely to be more effective than any of them on their own. So next slide. Now the triptans, I'm the person who did the study for this with Zomig. We used a big dose of that in the aura in people who had migraine with aura. So before the headache started, if they had flashing lights, they could be given the zolmitriptan, and we didn't find it stopped the aura. And indeed, it didn't change the number of people requiring another dose to treat the headache. So the conclusion was that there wasn't actually any evidence that the triptans worked before the headache started. It was actually a headache treatment. So the aura kind of allows you to go and get ready to take the treatment. Then you take it at the beginning of the headache, and treating it mild will do better than moderate, and moderate better than severe. And we haven't got a great deal of evidence of doing studies where two triptans are used in the same attack, but theoretically there shouldn't be a major issue, but we suggest that they're not, because they're not licensed for use in that way. So the GPANT that I mentioned is called rimagepant. There are two drugs in this family. We'll mention the other one in the preventative slides, but rimagepant 75 milligrams is the one that could be used for people who failed a couple of triptans. You have to be shown after a treatment pack of 8 that it works better than any of the other rescue medications, and if it does, then you can be given up to 8 a month as rescue on a repeat prescription, but not yet in southeast London. But if you lived in Kent, you could be on that at the moment. Right, so what would be your sort of goals if you're thinking about the treatment? So whether you use, it doesn't really matter what you use as long as it works. And so what would be your goal? Well, we would be wanting you to be sort of returning to normal activities within a couple of hours. I think that we should have a priority to find the right preventative that allows people to achieve that in most people. Could you just go back the slide? I missed the bottom point. And it may be, yes, that some people actually become quite sophisticated and might have, naratriptan on a Sunday afternoon when they don't want a side effect, but if they're about to give a talk to a group of patients and they need to clear their headache, they may put up with a side effect with a more powerful triptan because they want to feel a bit more kind of wired for that particular presentation. So it may be that it isn't, there's differences between patients, but there's also differences within the same patient for their requirement with different attacks. Yeah, the next slide, Shabana. So there are different ways of actually considering how you approach it. So basically the stepped approach is that everybody starts off with 2 aspirins, and then they do maybe 3 aspirins. If that doesn't work, the next attack, and then the next attack you might go to a more powerful non-steroidal, but you follow the same stepwise pattern. There are alternative strategies. So the strategies where we call it stratification. So the people with the more problematic headaches will probably need more powerful treatment. So we start them at a different part of the escalator. And then there is something called staging, which is where you have an initial treatment. So you maybe take your aspirin, Nurofen in your aura, and if that stops the headache from developing, you don't need anything else. But if the headache develops, you take a triptan to rescue that situation. So you can use various of the different things in single attacks and not necessarily have to use all of them every single time, but you might have a strategy that you develop which employs parts of all of these different families of drugs. Okay, next slide. I think this is the last one for rescue. So this is basically, it's saying that you need the right dose, the right drug, but also the right dose, and you need to understand the timing and the type of form of the mode of administration and the headache and the person. So there's a lot that can come into this. There may be, for most people, any of these above will work. It happens I'm somebody who will respond to a drug that doesn't work for many, which is paracetamol. But on the other hand, you might have somebody at the other end of the scale who there's one particular combination of things that are very important to get exactly right for them to get a good outcome. Now, Shabana, I can see you there. If you could nod, does that all sound reasonable? Were there any
Yes.
points that occurred to you as I was going through it?
No, I thought it was very clear. It makes things,
Okay.
and it's very organized as well. So step by
Okay.
step. So thank you. That's wonderful. I'll go to the
So then if
next.
you go over to the preventative side, and we'll do
Yes.
another quick run through that. I think the preventatives probably won't take as long for us to go through, but I think I'd just like to introduce them to you.
Hmm.
So for migraine, we have preventatives are things you take every day to try to avoid the next attack. So if you just do the next slide. Can you do the next slide, Shabana? Okay, so these are daily medication. The classical view is that you need to be on something for a long time to know whether it's working. I think this is particularly true if you have relatively low frequency. So we normally say that if you have an attack a week or more than 2 days a week affected, you're probably going to need a preventative. If you're on a preventative, you need a bigger dose or a different preventative. But we used to say that you needed to do months on a dose. In fact, people will give up with the drug if they don't get efficacy, usually within a few weeks. So I think we tend to be a bit more aggressive now with the introduction of these medications. And we should also try to still be aware that we need to treat the worst of the breakthrough attacks as well. So these are parallel. These are not either or. They're a sort of parallel thing with the rescue drugs. So next slide. So what we want to do is to reduce the frequency of the attack. So if you are having, say, 4 attacks a month, we'd be aiming to get to 2 or less a month. So we were not necessarily going to stop them completely, but what we want to do is to minimize the number of attacks. And there's an argument that it may even lower the threshold and make it easier for you to use your rescue medications. So the number of attacks or the number of days might be one of the indicators for the use of a preventative. Classically, it was 2 or more attacks a month, but we tend to say now weekly attacks. Um, if the treatments that you use as rescue, you've done the best you can and nothing's working, you need to do something else. We still may use preventatives in that situation. And some people just want to do it. They would prefer to be on a preventative. That it's a sort of security blanket that they would prefer to deploy right from the beginning. Um, the third point there is really a reference back to that issue about regular medications that were designed to be used for rescue medication may actually lead to higher frequencies, the so-called medication overuse. It's as little as 2 doses a week of any of the rescue drugs a week, not a day. So a lot of people are going to be slipping into that without intending to. Next slide. So these are some of the non-drug approaches. There's lots of things that have been suggested over the years, but the ones with the best evidence of magnesium, vitamin B2, that's riboflavin, and coenzyme Q10. Vitamin B2 needs to be, you can't use a 1B on its own. So you'd normally have 100 milligrams of the, or 100 mil of the vitamin B complex, and then another 300 of the vitamin B2, and that together makes up the 400 milligrams. Um, Vitamin B2 and coenzyme Q10 often give more energy, and that's often a problem for people with frequent headaches. They feel tired, and magnesium gives more clarity. The negative side effects are that the magnesium can make you looser with your motion, so not everybody tolerates it. And the vitamin B2 gives you bright orange urine, which is more of a party trick than a problem. But bottom line is that those are the ones with the best evidence. Vitamin D, which is a little bit of a sort of witch oil these days, or for the it's in flavour for many different conditions. Um, the evidence isn't strong for vitamin D, but nevertheless, vitamin D is something that is being used in quite a lot of other conditions at the same time. So the three with the best evidence are magnesium B2 and CoQ10. All three of them are in something called Dolovent, Dolovent, which can be bought online or via a telephone number. It's quite expensive. It's over £50 for a month's worth, and you'd probably need to be on it for 3 months for each of the three to have had a proper trial to see if it's going to work. On the other hand, you might consider buying them individually. Next slide. So other things that don't involve tablets, particularly youngsters, for instance, when they come in, parents are very nervous about giving them straight away prescription medications, but you could look at the foods you're eating to see if there's something that you're reacting to. That's called hypersensitivity and food testing, York test. There's a device which is like a TENS machine at a different frequency called York, called Kefli device. Um, some people use MigraLens glasses. I didn't put that on this slide. So if you're very sensitive to light, so those are the top end that you could do yourself. There are devices that you can buy additional to the Kefali, which we haven't had so much success with. Vagal nerve stimulations, where you hold something to your neck and it makes your face droop and may affect the vagal nerve, which is your autonomic nervous system. There's one that you hold a device and it gives you a magnetic wave. That's called transcranial magnetic stimulation. We haven't had so much success in my clinics with those two. And for people who who fail everything, even in all the tablets we're going to talk about, we sometimes use something called vagal nerve stimulation. This is like a pacemaker box with the wires going onto the nerves at the back of the head. And it's in the most refractory patients. So there's a whole kind of collection of things there, which are not necessarily medication, starting with the things you can do yourself, going right the way through to tertiary care, using those kind of complicated devices. So next slide. I tried to just do a bit of a summary. I've updated this from the previous one that was based upon a paper from 25 years ago. So there's some things in here that weren't in that original paper. But the most commonly used first-line medications are beta blockers. People will probably recognize Inderal or Inderal LA. That's propranolol. 80 or 160 milligrams is the dose for migraine. But there are smaller doses of the non-slow release traditional sort of multiple times a day dosing as well. Amitriptyline's another of the old ones, starting at 10 milligrams. Most end up 30 to 80 milligrams. So it's 10 milligram titration every week. It is the other old one is Pizotofen, which is in the second line drugs, 0.5 to 1.5 milligrams. And then the newer drugs are Candesartan, which is now first line, very low, quite a low side effect drug, starting at 4.8 at night, and topiramate. But we don't use so much topiramate now than a few years ago because of the risk of fetal abnormality and miscarriage. So it has to be, you have to have a safe form of contraception, which effectively means for the ladies they'll need a Depo-Provera injection or coil. There are some other things that I've on that list which we don't really use so much these days. So methysergide is no longer manufactured anywhere in the world, but was one of our mainstays 25 years ago. Periactin is cyproheptadine. It's an antihistamine. Sometimes antihistamine drugs work. Sodium valproate is in the same category as the topiramate with the fetal abnormalities and isn't really used. I think most people would use the topiramate ahead of the sodium valproate. Next slide. And again, next slide. So this is just a few of those slow release versions. It's much bigger doses than the doses that would typically be the standard doses for a standard salt. So it's the slow release up to 160 milligrams is actually the typical dose for migraine. Next slide. Candesartan is another blood pressure drug, works in a different way to propranolol, rarely overshoots with too low blood pressure, but could potentially. It's used as a protector for your kidney in people who have diabetes. And so if you had high blood pressure and headaches, these are the drugs that you'd want to be using because you could kill two birds with one stone. Next slide. So the anti-epilepsy ones all have issues. So gabapentin has been shown not to be effective for straightforward migraine, works in neuropathic pain. And I mentioned the problems with the drugs valproate and topiramate. Next slide. So if amitriptyline is the drug you use if you have daily chronic tension type headache, the non-migraine headache, so it's a broad drug. It works in neuropathic pain as well as working in migraine and background headache. So it's not one of the biggest messages we have to get over is this: we're not giving you because we think you're depressed, we're giving you for pain, and it starts with a low dose and goes slowly with an escalation. And if it causes side effects, there's a gentler one called imipramine and another family, SNRIs. Next slide. So we had the 5-HT1 receptors, and this is the 5-HT2 receptors. So the Pizotofen is the one that's still around, and it's got a license for use in children. Methysergide no longer made, but it's one of the old drugs as well. Makes people a bit tired on occasions. And these calcium blockers, There are people who like to use them, particularly if there's a lot of aura, non-headache manifestations, and flunarizine is often used in children, but it's not necessarily universally used across the whole of the specialist clinics. It's just a couple more slides. So basically, for people who don't find they get a response and they fail 3 of those preventative 5 major drugs, we now have the CGRP, both the GPAMP blockers, there's one called Tadalafil, and monoclonal injections. The blockers are not available yet in Southeast London, but the monoclonal antibodies are. So they can be used for 4 or more migraines. The Botox requires chronic migraines, so we measure headaches, not migraines, but you have to have headache more days than not, of which at least 8 days have migraines, so different rules. So they're rules laid down by NICE, and then there are another rules for when they have to be stopped, either continued or stopped at 6 months. And then we mentioned the implant of the occipital nerves. We can do in the clinic blockers using steroids, like people have for tennis elbow. And then I did put it in just because for interest. We did some studies years ago looking at whether holes in the heart would lead to more headaches, and we didn't find that closing holes for headache made a difference to the headache. Next slide. I think we're probably near the end of this. So that's just your last slide, saying that basically for rescue medications, we're wanting consistency and back to normal within a couple of hours. And for preventatives, we're wanting to reduce the numbers of attacks and possibly make it easier to use the rescue medications. Is that the last one? Is that the last slide? Yeah. Okay, so I'm sorry if I might have run over by a minute. Were there any things that struck you as you just looked at that, Shabana, that you wanted to ask? Because anything that you're thinking is probably somebody else thinking as well. Oh, you're on mute.
Sometimes we get headaches after meals or after eating something in particular. And
Triggers.
yeah, I
Yeah,
think the triggers.
yeah.
And sometimes it's also if you like if you have a workout on an empty stomach, for instance, and it gives
Yes,
you
yeah, yeah.
headaches. So there are so many triggers.
Yeah,
And
we didn't go into triggers in a big way, but there's lots of websites where you can look at them. But it's often changes to your internal or external environment if you have that oversensitive migraine brain. So the classic one for your lady would be the change of the time of the month. So where the estrogen drop just before you're about to have your period, that's called menstrual migraine. If all the attacks are day -2 to +1, it may be times of the day as your kind of level of alertness changes. So quite commonly people waking up with headaches. Something like over half the headaches wake you early or in the first hour of waking. Then it could be dehydration, or missing a meal or particular foodstuffs, cheese, chocolate, citrus fruits. The
yes,
York
cheese.
test,
Yeah.
the York test is the one that I'd suggested, that it looks at 200 foodstuffs. So if you don't have an antibody, that one's safe. If you have an antibody, it may be doing nothing at all or causing you to have some itchy skin rather than headaches, but at least it would tell
Mm.
you what you've got a reaction to as a starting point. And then you've got all the external things. So, the strong smells, petrochemical smells, or the
Mm.
thundery day, or the bright sunlight where the migrolens may come in. So, changes can often be triggers to somebody's susceptible brain. Spot
And
on.
these don't have to be taken extremely seriously, is it? I mean, can you ignore
Well,
them?
no, I mean, often people will actually identify those things and try to rectify them.
Mm.
Um, by the time people come to clinic, us finding, it's not common for us to find a food trigger. So people have often thought about that quite a lot before they see someone in a specialist clinic. And we normally direct them to places like the York Laboratories York test to see if there could be more gathered, gleaned from that sort of investigation. Um, you know, I don't think triggers should be taken lightly. I think, lifestyle and triggers are an important part of the management of headache. So if you have an irregular lifestyle, you go to sleep at different times during the week, or you're doing shift work, that can be part of the disruption. So regular fluids and food and sleep pattern and exercise are all things that generally help with headaches. And then if you can identify a trigger and avoid it, fortunately you may not avoid the thunderstorms. Basically that would be also a perfectly reasonable way of attacking this. I mean, we have comorbidities in patients, so if you get sleep disturbance, addressing your sleep hygiene can help. If you've got mood disorders, addressing that can help. If you've got a stiff neck or other sensitive nerves elsewhere in the body, addressing those can help. So it becomes quite complicated for the more complicated patient, the more kind of patient who's got a kind of refractoriness to other treatments. But the broad principles are similar. What we're trying to do is to push up the threshold with preventatives and break cycles of headache. The uncontrolled headaches gives more headache. The regular painkillers give more headache. So if we can reduce that, then the use of preventatives can actually help, and we can minimize the overall kind of pattern and reduce the requirement for rescue.
Thank you.
Okay,
Thank you.
good.
So that was a very informative session. Thank you for doing this.